last antibiotic might just be your favorite. Metronidazole is a drug that in anaerobes gets converted to free radicals. It's this free radical mechanism that ends up killing the organism. The conversion takes place with ferredoxin, which can then bind to DNA and other macromolecules, resulting in a bactericidal effect. It's the spectrum of this drug that makes for the best test question, though. You'll notice that metronidazole kills protozoa, including Giardia, Trichomonas, and Entamoeba. If you'll organize those and take the first letter of each organism, you can form the word GET. GET, Giardia, Entamoeba, and Trichomonas. All three of those are popular test questions about treatment. When it comes to killing bacteria, metronidazole is great for anaerobes. Specifically, we like to ask about Bacteroides. Maybe you can come up with capital B and little a, and Clostridium, and that includes Clostridium difficile. So if you extend your mnemonic, now you have the word get followed by bac. Notice we also have the organism Gardnerella. Gardnerella, a cause of bacterial vaginosis. This is another popular test question today, so we somehow have to work that into our mnemonic. But folks, really it's no problem if you're hip and modern like me. You just simply say, get back on the metro, G. Are you with me on that? Get back on the metro, G. You have to be pretty hip, though, in order to say something like that. Remember, all of those organisms are going to be killed effectively by metronidazole. When you take this drug, patients most often complain of a metal taste in their mouth. It's annoying, but not necessarily serious. You also have to be aware of a disulfiram-like effect of metronidazole. And when you think about that, that means that just like the drug disulfiram, we're going to inhibit the metabolism of alcohol, specifically by blocking the enzyme acetaldehyde dehydrogenase. So if you take metronidazole and drink alcohol, you're going to accumulate acetaldehyde, which results in nausea, vomiting, and headache. Make sure and make your patients aware of this fact. If you look in the margin, there's a clinical correlate on H. pylori. You might have noticed that I've intentionally skipped this organism in the coverage of our antibiotics. It's because now we can put all the things together that we're going to use for H. pylori eradication. There is a mnemonic that includes all 4 antibiotics that are likely to be used for H. pylori. The mnemonic is MCAT, M-C-A-T, kind of like the MCAT gave you ulcers. So M is for metronidazole, C, clarithromycin, A, amoxicillin, and the T for tetracycline. Most often what you're going to do in order to get rid of H. pylori is use a 3-drug combination. The most popular is to take 2 antibiotics, clarithromycin and amoxicillin, and combine it with a proton pump inhibitor like omeprazole. So 2 antibiotics plus a PPI. That leaves you with a backup regimen of metronidazole and tetracycline if necessary. Sometimes we can do the BMT regimen, which includes the drug bismuth added to the 2 antibiotics. This chapter ends with a discussion of anti-tubercular drugs. When we think about the treatment of tuberculosis, the rule here is combination therapy. We use combinations for the treatment of TB, and that includes 2 to 4 drugs. Occasionally, even a 5th or a 6th drug can be added to the regimen. For prophylaxis of TB, isoniazid is clearly the most popular drug, but rifampin becomes our best backup drug. And in suspected multi-drug resistance, we may actually use both drugs for prophylaxis. The way that this table is organized is very effective at showing you the most important TB drugs at the top, and that would include isoniazid and rifampin. There's so many features of these drugs that you need to know for your test that I've boxed off the whole thing on this slide. But let's start with a way to remember the TB drugs. Some folks have learned the mnemonic RIPE, R-I-P-E, as a way to remember 4 very important TB drugs. But my mnemonic is different. I use Respire. And the reason I go with Respire is 2 reasons. 1, Respire makes me think about lungs, and lungs makes me think about TB. Respire also includes 5 drugs, all 5 of the ones listed on this table. So R for rifampin, E for ethambutol, S for streptomycin, P, pyrazinamide, and the I for isoniazid. Notice little r, little e don't stand for anything. So perhaps that's helpful to remember all 5 of our very important TB drugs. We start with isoniazid. Probably you need to know more about this drug than any other in this table. The mechanism is that it inhibits mycolic acid synthesis. Remember that mycolic acids are unique to mycobacteria. So perhaps you're asking yourself, what else can we use isoniazid for? And the answer is we really just use it for TB. It's very specific for this organism. The drug is a prodrug. You have to convert isoniazid to its active form by an enzyme called catalase. When the bacteria do this, this drug is effective at killing TB. On the other hand, how do you get resistance to isoniazid? What if the organism deletes the gene that encodes for catalase? Now you've got a prodrug that is never going to be converted to its active form, and that's how you get resistance. Side effects include age-dependent hepatitis. Very popular test question about peripheral neuritis. This is the reason why you supplement with vitamin B6. Isoniazid, in fact, mimics a B6 deficiency. So when you supplement with vitamin B6, you can overcome this particular side effect. Similar, isoniazid causes sideroblastic anemia, where you can also use B6 to overcome that. And finally, isoniazid is one of our big 3 lupus-causing drugs. Remember, it's hip to have lupus. Hydralazine, isoniazid, procainamide. Really, hydralazine and procainamide are way more popular as test questions because isoniazid, even though it was the drug that we discovered drug-induced lupus with, of the 3, it's the least likely to actually cause it today. Perhaps that's because we're using it in combinations with other drugs at lower levels and therefore less likely to get drug-induced lupus. The second drug in the table is rifampin. It's a drug that inhibits DNA-dependent RNA polymerase. And that enzyme is not only found in mycobacteria, it's found in other bacteria as well. So rifampin is a more broad-spectrum drug that can be used to kill TB and other bacteria. Its side effects include hepatitis, but also the fact that it can induce P450 enzymes, and that can lead to a number of drug interactions. Perhaps my favorite is an interaction between rifampin and oral contraceptives, where this drug is going to reduce the effectiveness of your oral contraceptive. The fact that this drug causes red-orange metabolites also makes for a good test question. Fluids will turn red-orange in color. That includes tears, sweat, and urine. It can even stain your contact lenses. But don't you think you should make folks aware that their urine might turn red-orange in color? Certainly that is an outstanding feature for rifampin. Next, we have the drug ethambutol. It's unlikely that you get a mechanism question about this drug. It is a cell wall synthesis inhibitor. It's the side effect of ethambutol that's a popular question. It has dose-dependent retrobulbar neuritis that can lead to decreased visual acuity and red-green color discrimination. In essence, ethambutol can lead to red-green color blindness. You can have trouble discriminating between those 2 colors. For pyrazinamide, make sure you know the side effect of hyperuricemia. Almost everybody who takes pyrazinamide gets hyperuricemia. It doesn't always result in gout, but it certainly predisposes you to getting gout. And finally, streptomycin. Streptomycin is an aminoglycoside. We've covered aminoglycosides earlier. We know that they're protein synthesis inhibitors and that they work at the 30S ribosomal subunit. The side effects include nephro and ototoxicity. Do you remember the third side effect? Muscle weakness because of inhibiting acetylcholine release. In the margin is a clinical correlate about isoniazid prophylaxis. When you get exposed to TB, even if you're TST negative or young kids, isoniazid can certainly be useful as a prophylactic agent. If you have TST conversion in the past 2 years, or if you're in one of these high-risk groups, you're a diabetic, you're immunosuppressed, if you've been on glucocorticoids for long term, and HIV-positive patients, for example, are all more at high risk and can benefit from prophylaxis with isoniazid. If you cannot use isoniazid, rifampin becomes our next best option for prophylaxis. In the margin is a note about Mycobacterium avium, an organism that we often abbreviate as MAC, for Mycobacterium avium complex. When you think about this organism, it shows up when you have a very low CD4 count. In fact, your count has to be down around 50 or less, typically for you to see this organism occur. In the context of a patient with HIV, as their CD4 count is declining, what you're most often going to do is start them on prophylaxis for MAC as their CD4 count is approaching 100 or less. So the most popular drugs are azithromycin or clarithromycin. It's a prophylaxis question more popular than a treatment question because as you see the CD4 count decline, better to prevent than to wait till it occurs. The phrase that you can remember, if you'll remember MACs for MAC, how do you treat the organism MAC? With macrolides. You use the A, azithromycin, or the C, clarithromycin, as the most important preventatives for this organism. Now that we've finished our chapter on antibiotics, let's do 3 questions together. Here's the first one, so pause the video and review, and we will discuss. A 33-year-old immigrant from Peru comes to a women's health clinic. She's missed her period for the past 2 months. When her pregnancy test comes back positive, she becomes distraught, saying that she's been on the pill for the past year and has not missed a single dose. When she starts to cry, her tears are noted to have an orange tint. Come on, folks, you know that was the real clue, right? The physician tells her the most likely reason her oral contraceptives were ineffective was an interaction with one of her medications. But we want to know, what was she being treated for? Clearly, you have to recognize that with the tears having an orange tint, that this woman was taking rifampin. Rifampin has that ability to turn fluids red-orange in color. Rifampin also has important P450 inducer effects that can lower the effectiveness of oral contraceptives. The remaining question is, what do you use rifampin for? And of the choices, of course, it's E, tuberculosis. Here's question number 2. Once again, pause the video and review on your own, and we will discuss. A patient is admitted to the hospital for head trauma. She is intubated for hyperventilation and a subsequent craniotomy. When she develops ventilator-acquired pneumonia, she is placed on imipenem-cilastatin, linezolid, and 3 days of gentamicin. 4 days after beginning antibiotics, her creatinine rises and she starts having seizures. What is the most appropriate next step in the management of this patient? You probably found this as a difficult question, but the key was to recognize that over time this patient started developing renal dysfunction. Notice her creatinine rises, and that resulted in her having seizures. So what was the most likely cause of the seizures in this case? Perhaps it was accumulation of the drug imipenem. The correct answer here is B. Stop imipenem, because in patients with renal dysfunction, this drug accumulates to the point where you might get seizures. Other options you would have to rule out. For example, choice A, start therapy with ethosuximide. This drug is very limited in its use for seizures. In fact, only used for absent seizure. And since we don't know what type of seizure this patient is having, not the best choice. Linezolid most likely did not contribute to causing the seizures. Its side effect is more on lowering your platelet count. Adding gentamicin back to the regimen. In fact, gentamicin might have been a contributor to some of the nephrotoxicity here. But we only did 3 days, and this was happening 4 days after beginning antibiotics. And choice E, adding a macrolide to the regimen, is not going to help to reduce her risk for seizures that was happening because of the renal dysfunction. Here's question number 3. Pause the video, and then we will discuss. A 26-year-old man presents to your office complaining of cramping and abdominal tenderness that is relieved by bowel movements. Greenish watery diarrhea, 5 to 10 stools daily without hematochezia or melena started about 5 days ago. The patient reports taking amoxicillin clavulanic acid recently for an ear infection, which has since resolved. You decide to place him on another antibiotic for his current symptoms. While taking this new drug, he should be advised to avoid which of the following during therapy. Multiple steps in this question that you have to solve. First, you recognize the greenish watery diarrhea as a C. diff infection, especially since he was taking antibiotics previously. If it's C. diff, the drug of choice is metronidazole. And while you're taking metronidazole, you should caution your patients about drinking alcohol. The correct answer here is choice E, wine. You might notice that the other options here make for very interesting and possible answers to other test questions. When you think about cheese, perhaps you're thinking about tyramine and its interaction with MAOIs. When you think about milk, dairy products, certainly the chelation with tetracyclines comes to mind. When it comes to sunlight, phototoxicity for fluoroquinolones, tetracyclines, and sulfonamides. Tobacco, well, that one's easy. Everybody should avoid tobacco.